Okay, hi everybody, and thank you for joining today's CMS Web Interface Support Call. During this webinar, CMS will provide an overview of 2019 CMS Web Interface Quality Reporting for MIPS groups and ACOs. And after the webinar, CMS will take as many questions as time allows. So now I'll go ahead and turn it over to Lisa Marie Gomez from the Center for Medicare and Medicaid Services to begin.
Welcome everyone, and thank you for joining us today as ACOs and MIPS groups and virtual groups prepare to report quality data reporting via the CMS Web Interface. I'm a subject matter expert regarding the CMS Web Interface, and joining me today are other CMS subject matter experts and contractors who will share helpful information regarding quality data reporting through the CMS Web Interface, and we will answer your questions during the question and answer session after today's presentation. Today's call is focused on quality reporting. If you have any questions regarding promoting interoperability, improvement activities, MIPS, or general questions regarding quality reporting, you can contact the Quality Payment Program Service Center. Next slide, please. Before we begin this presentation, we just want to note that the information presented in today's presentation is current at the time of publication. Medicare policy changes frequently. We encourage you to review and use the source documents and links that are provided throughout this presentation. And please stay tuned for any communication from the Quality Payment Program, Medicare Shared Savings Program, or Next Generation ACO model regarding any updated information. Next slide, please. So the resources listed on this slide are now available on the Quality Payment Program Resource Library and Webinar Library. We encourage you to take a look through them, and if you haven't already done so. Next slide, please. So the submission period for the CMS Web Interface aligns with other submission types for the 2019 performance year, which opened on January 2nd, 2020, and will close at 8 p.m. Eastern Daylight Time on March 31st, 2020. Once the submission period closes, the CMS Web Interface will automatically accept your submission. As a reminder, the CMS Web Interface is accessible using the sign-in link on the Quality Payment Program website. Next slide, please. As you may know, today marks the start of a series of CMS Web Interface support calls held weekly throughout the data submission period. The next support call will be held next Wednesday, January 22nd, 2020, from 1 to 2 p.m. Eastern Standard Time. Topics will include the high priority bonus, the end-to-end bonus, assignment and sampling FAQs, and frequently asked measure questions. Additional topics may be added prior to the support call. Next slide, please. So please note, in regard to other CMS approved reason skipped requests, they must be submitted through the CMS Web Interface. A CMS approved reason is a way to skip a patient attributed to a measure during denominator confirmation, and it is reserved for circumstances that are unique, unusual, and not covered by any of the denominator exclusions or denominator exceptions identified in the measure specifications. However, please note that if a patient is skipped, another one will need to be reported in their place to meet the measure requirement. Also, as a reminder, the 2019 CMS Web Interface measure specifications and supporting documents are available on the CMS website, which is the Quality Payment Program Resource Library. We encourage you to review all the updated documents, early each year to review any changes that may have occurred between and during the performance years. In addition, I just also want to note that the 2020 CMS Web Interface measure specifications and supporting documents are now available on the Quality Payment Program Resource Library. So again, we just want and encourage you to review the materials that are currently available to you. Next slide, please. Now I'm going to turn the presentation over to Laura Hasey to discuss Prev 10 reporting. Laura?
Thanks, Lisa Marie. Next slide, please. For the 2019 performance year, Prev 10 questions in the CMS Web Interface remain synchronized across the population. So you'll answer one set of questions that will be divided into the populations for Prev 10. It's the same as we did for last year for the 2018 performance year. Next slide. As you'll see on the data entry screens, once you answer a question for Prev 10, you'll see on the right side some contextual help that lets you know what the answer to your question, which population that answer goes to. Next slide. To see all three populations and how your patient sample is calculated in each, you can visit the Measure Rates report from the View Reports page. In the Prev 10 section, you'll see performance per population. It's a drop down, and when you open that up, you'll see each population separated, and you can see the numerator and denominator for each population. For population 2, please note we've grouped non-smokers as denominator exceptions in the user interface to remove them from the denominator of this population. You might notice a higher denominator exception count because of this. Next slide. And I'll pass this over to Kristen Williams.
Thanks, Laura. Next slide, please. The first question we have for assignment and sampling is, what if one or more of our CMS web interface measures contain fewer than 248 ranked patients? And the answer is not every CMS web interface measure may have a sample of 248 patients. This is particularly true in measures for diseases that have low prevalence rates. If CMS was unable to identify a minimum of 248 patients who met the sampling criteria, then all patients who meet the criteria will be sampled. If fewer than 248 patients are found eligible for a CMS web interface measure, then the ACO or MIPS group should report on all eligible patients. Question 2. Will all of our assigned or aligned patients be populated into the CMS web interface? And the answer is no. Patients will be sampled randomly. For ACOs, it is based on third quarter assignment or alignment into the CMS web interface using the specifications in the 2019 web interface sampling methodology document posted on the QPP resource library. Next slide, please. Question 3, will the CMS web interface use a health insurance claim number, HICN, or a Medicare beneficiary identifier, MBI? And the answer is the 2019 patient samples may include some patients that are identified with the HICN, although the majority will be identified using an MBI. Question 4, does a patient need to have a visit in the measurement period to be included in the hypertension measure denominator? And the answer is yes, using Medicare administrative data or claims data from January 1st, 2019 through October 31st, 2019, CMS will exclude from quality measurement eligibility any patients with fewer than 2 primary care services within the organization during the performance year. Additionally, to be eligible for the hypertension web interface sample, patients must have at least one eligible encounter with a diagnosis of essential hypertension 1 year prior to the measurement year or during the first 6 months of the measurement year. Next slide, please. And now to Angie, who will be doing a Prev 10 measure overview.
Good afternoon. This is Angie Stevenson from the PIMS Measures team to provide a brief overview of the Prev 10 tobacco use screening and cessation intervention measure. Next slide, please. The intent of the Prev 10 measure is to screen for tobacco use and provide tobacco cessation to tobacco users. In 2018, guidance was given that tobacco screening should be completed for smoking and smokeless tobacco in order to meet the screening portion of the measure. Screening for both types of tobacco was required. For 2019, per clarification from the measure steward, as long as the patient is screened for tobacco, regardless of the type of tobacco, that would meet the screening portion of the measure. So screening for either smoking or smokeless tobacco is acceptable. Screening for any type of tobacco is acceptable. You can find the CMS web interface, measure specifications, coding documents, and release notes for all program years on the Quality Payment Program Resource Library. Next slide, please. Here are some additional Prov 10 clarifications from the Measure Steward. Tobacco products include smoking tobacco, such as cigarettes, cigars, pipe tobacco, and smokeless tobacco, such as chew and snuff. E-cigarettes and vaping are not classified as tobacco products, and usage is not captured by the measure as either tobacco use or as a cessation aid. Also, marijuana is not considered a tobacco product, and usage should not be included in this measure. Thank you. Now I'll turn it over to Lisa Marie Gomez at CMS.
Thanks, Angie. Before I go over resources, I want to discuss the 2019 Performance Year Prov 12 measure, specifically the Prevention, Care, and Screening for Depression and Follow-Up Plan measure. So over the last few months, we have received various comments and questions from stakeholders, and thus we assessed the measure. As a result, we are changing how the 2019 Performance Year Prov 12 measure is scored. For the Medicare Shared Savings Program and the Next Generation ACO model, we are changing the measure from pay for performance to pay for reporting. And for purposes of MIPS, the measure will be excluded from scoring. It should be noted that ACOs and groups will still need to meet reporting requirements for Prov 12, even though the measure has been changed to pay for reporting for the Medicare Shared Savings Program and the Next Generation ACO model, and for purposes of MIPS, excluded from scoring. During next week's support call, we will discuss the 2019 Performance Year Prov 12 measure reporting requirements as one of the topics discussed, at which time we will address Prov 12 questions. We appreciate your patience in holding your Prov 12 questions to next week. So now on to resources. So the next few slides will outline the available CMS web interface resources. Next slide, please. Please note that the 2019 materials providing information on the MIPS Quality Performance category are available on the Quality Payment Program Resource Library. We encourage you to review these resources if you have questions on quality requirements and measures. We'll continue to communicate any future postings and upcoming support calls. Next slide, please. The Quality Payment Program webinar library also contains recordings, slides, transcripts from past QPP webinars, including the recent 2019 CMS Web Interface user demonstration held in November and the CMS Web Interface kickoff call, which was held in December of last year. Additionally, the Help and Support page on the Quality Payment Program website contains links to materials such as videos, webinars, and courses, as well as other items to help with reporting and development. Next slide, please. Finally, this slide contains links to resources available for the Medicare Shared Savings Program ACOs and the Next Generation ACO model. We encourage you to review the materials available here and sign up to each newsletter for more information. Next slide, please. If you need additional assistance, please refer to the contact information listed on this slide. Next slide, please. Now, just before we go into the Q&A portion of this call, if you're interested in providing feedback and collaborating with CMS on the Quality Payment Program, we encourage you to participate in our human-centered design efforts. To get involved, please email your name, title, topic of interest, and organization to qppuserresearch@cms.hhs.gov. Now I will turn this portion of the support call to Lauren Kiefer to begin the Q&A session. Lauren?
Great, thank you, Lisa Marie. All right, everybody, we are now at the question and answer portion of the webinar. You, again, can submit your questions two ways. Please do so via the questions tab on the go-to menu on your screen, and we will read it out loud for it to be answered, or you can also raise your hand icon and we will go ahead and unmute your line. You'll see that you've raised your hand when it is a little green icon next to your name. All right, so first question we have for you says, is there a known glitch with data entry in QPP for Prev 13? They're asking because when risk categories 1 and 2 are called no diagnosis, some beneficiaries, you can continue to risk category 3, and other times it automatically skips the beneficiary.
And this is Deb from the PIMS team. The thing that happens with Prev 13 is there is a different age criteria for the third risk category. So I know in the past what occurred, and there may need to be some verification from the program people, but what would happen in the past is if you did not confirm diagnosis for risk category 1 or 2, you wouldn't get to risk category 3 if the patient's age was outside of the patient criteria for risk category 3. It would automatically skip them. However, if you did not confirm the diagnosis for risk category 1 and risk category 2, and they did meet the age criteria for risk category 3, you would be able to answer the additional questions for that risk category. Thank you.
Great, thank you for clarifying. All right, next question is concerning Prev 10. It asks if our staff offered tobacco cessation interventions or pharmacological therapy, but the patient declines, does this still mean that the client received tobacco cessation?
The answer to that question is yes, it would. They're performing the quality action as defined within the numerator, and just because the patient declines does not exclude them from performance. Thanks.
Thank you. Next question just states that the specs do not state what to do if the patient declines, which we actually just answered. So we'll move on to, for HTN2, if the most recent BP is from an urgent care or ED visit, can they still use it?
Hi, this is Katie from the PIMS team. So although the measure is intended to be outpatient, blood pressure readings from any clinical setting are acceptable when reporting the numerator. So it would be appropriate to move to the next most recent blood pressure if the most recent is from an ED or inpatient setting and is not within normal parameters. The other caveat to that is move to the next most recent if it's taken on the same day as a diagnostic test or diagnostic or therapeutic procedure that requires a change in diet. Thank you.
Great, thank you. All right, next question is also about Prev 13. So which category do you enter for the denominator exclusion for ESRD?
This is Deborah again, and that would really depend on where you are as you're walking through your submission guidance. So again, you want to go ahead and follow the specification because you're going to step through each of these risk categories in order. So if you get to the point where you know the patient has a diagnosis of ASCVD, but they have the denominator exclusion as well, you would submit your denominator exclusion at that level. My recommendation would be to go ahead and walk through each of the populations because it is possible that you're not going to confirm that patient at all, and so there would be no reason to select the denominator exclusion. As opposed to if you are going to confirm that patient meets the denominator criteria based on the diagnosis, at that point you may want to go ahead and select the denominator exclusion if the quality action is not being performed.
Great, thank you. All right, next question is concerning Prev 6. It asks, is a beneficiary with another type of cancer a good example of a patient to request a manual skip for? They're asking because if a patient already has cancer, you likely would not screen them for another type of cancer or put them through a colonoscopy while they're undergoing treatment.
Hi, this is Angie Stevenson. I'm sorry. The Prev 6 measure does not allow excluding a patient unless they have a diagnosis or past history of total colectomy or colorectal cancer. You are welcome to submit a CMS approved reason request on the CMS web interface. You would need to have medical record documentation as to why the patient was not offered a colorectal cancer screening. Thank you.
Great, thank you. We have a few from the phone line, so we'll go ahead. Tammy Floyd will go. Oh, apologies, Tammy Floyd. You need to go ahead and enter in your audio pin to go ahead and ask your question. So please do so, and we'll come back to you. All right, Jazz Growell, we will go ahead and unmute your line. So Jazz, you may ask your question.
For the Prep 13 measure, it says that like the specs say that E78.0, like the code for pure hypercholesterolemia, is not enough to count for population 2. If the provider writes hypercholesterolemia and underneath it there's the code for E78.0 pure hypercholesterolemia, can we count that?
This is Deborah from the PIMS team. As long as your documentation supports the coding that you're used, you could use that. Our guidance is basically you need to be able to, in the event of an audit, support whatever it is you report with the documentation that you have. So we can't necessarily speak to your specific documentation. It's really at that level of what you're comfortable with. If you feel like by what you submit, if you were then subject to audit, can you support what was submitted by what is documented in the medical record?
Okay.
Thank you.
Great, thank you. All right, next question is just asking for clarification for what to do when the specs, when a patient declines for any measure.
Hi, this is Katie from the PIMS team. So I just wanted to clarify that the action you should take based on a patient declining is specific to each measure. So some measures do allow denominator exceptions for patient refusals, and some do not. So we just wanted to encourage folks to make sure you're reviewing the specifications for those specific exceptions. In the event there's no exception for patient refusal, then you would need to report on whether or not the quality action was completed. Thank you.
Great, thank you. All right, your next question asks, for DM2, if a patient did not have A1C test, would the numerator still be yes?
And this is Deb from the PIMS team again. Just to kind of point you to the measure specification, on page 8 of the posted measure specification within the submission guidance, it does state that if the patient did not have one or more hemoglobin A1C tests, that you should be documenting or documented select no. So let me read that again. Page 8 of the posted measure spec, if the patient did not have one or more hemoglobin A1C tests documented, select no. Thank you.
Great, thank you. Your next question concerns tobacco use. Our population includes patients that uses religious tobacco during certain ceremonies. Do these patients still count?
Hi, this is Jamie with PIMS team. For Prep 10 in this specific question, yes, this would constitute as tobacco use. Thanks.
Great, thank you. All right, we'll go to the phone line. Jason Shropshire, we will go ahead and unmute. Sorry, you just popped away. So actually we'll go to Rebecca Ferrand. Rebecca, we'll go ahead and unmute your line. And Rebecca, you may ask your question. Hi, sorry, Rebecca Ferrand, you may ask your question. Okay, moving back to Jason Shropshire, we will unmute your line. Jason, you may go ahead.
Hi, can you hear me?
Yes, you may go ahead.
So I have I guess a two-part question about Prep 12. I know that we can't ask questions about the measure specifically, but I'm asking a question about how we input the data into the web interface. So as part of the measure, you have to have the provider review the score and determine if they need to take any action. Where in the questions within the web interface does that fall? Is that part of the screening question or the next question talking about if they're depressed or not?
So Katie, I don't know how you'd be able to answer that question, but Katie, do you think you can address that question? Or Oslam, it sounds like it's more of an input in the system question versus relating to the actual overarching measure.
Would you be able to repeat the question, please?
Yeah, so as part of the specifications, you guys have told us that the provider has to review the screening and determine if the patient needs further evaluation for depression. So my question is, in the web interface, which question does that fall into? Because there are several questions that build upon each other within the spreadsheet. So I'm trying to figure out if let's say the patient had a PHQ-9, but the provider did not review it. Does that mean we say no, they weren't screened, or yes, they were screened, but no, it wasn't positive?
Jason, this is Deb from the PIMS team. I can see what you're asking. I think in the past the answer has been if there was no indication of whether or not a depression screen was positive or negative, there is no specific question in there to say, yes, we did the screening, but we don't know if it was positive or negative. And the guidance in the past has been, even though you know the patient has been screened, there's no way to determine if the outcome of that screening is positive or negative. So you would actually, the only option you really have is to select that the patient was not screened for depression.
Okay, thanks. And then just really quickly, so at the beginning of the call, someone stated that PREV 12 is going to be pay for reporting for 2019, but I noticed someone asked that clarification in the chat, and someone from the measure committee said, no, it's not, it's pay for performance. Can you please clarify which is correct?
So in regard to the answer that's right in the chat, I believe that the not was supposed to be now, not NOT, but NOW. So please ignore what was reply that said not. So as I stated earlier in the presentation, so for the 2019 performance year, PREV 12 measure, for the Medicare Shared Savings Program and the Next Generation ACO model, the measure is pay for reporting. And for purposes of MIPS, it's excluded from scoring. So again, it's pay for reporting and excluded from MIPS. So that is, and we will correct the response in the chat. Thank you.
Thanks.
Great, thank you. All right, next question asks, is a patient that is on antidepressant medications but has no depression diagnosis in the EMR be excluded from the PREV 12 quality measure?
Hi, this is Katie from the PIMS team. So in this instance, the antidepressant medication alone would not qualify for the exclusion, and this is due to the fact that some medications may be used for other purposes, such as smoking cessation. So we would look to have confirmation of a true active diagnosis of depression for the measure. Thank you.
Great, thank you. Next question asks, for Care 2, if we have a patient who has documentation during an encounter that they use a cane for mobility support, can this be sufficient to be considered for a falls screening?
This is Deb from the PIMS team. There really needs to be documentation in the medical record of a falls risk screening that includes one of the following: the patient's history of falls, a described fall, a note stating no falls, or an actual assessment of gait or balance. So you would need to look at what you have documented in the medical record and determine if it meets the definition of a falls risk screening and the guidance that has been provided in the measure specification that's posted. Thank you.
Great, thank you. Next question asks, does coronary arteriosclerosis count for the denominator for PREV 13 in denominator population 1?
So for all of the PREV 13 denominators, you're going to want to look at the posted coding that is also provided and determine if what you are looking at as a diagnosis for confirmation is covered within the coding provided by the measure developer as conditions that meet the intent of confirmation. Thank you.
Thank you. Right, we will go back to the phone line. Theodora Missouri, we're unmuting your line. So Theodora, you may go ahead and ask your question.
All right, can you hear me?
Yes, you may go ahead.
All right, thank you. So if in the documentation, and this is for Prep 10, if in the documentation it is documented that patient is a smoker, does this pass the screening part of the measure, as this does not differentiate between tobacco smoking and, smoking marijuana? And there's a second part to that question. If it is documented that patient is not a smoker, would that also pass the screening portion of that measure? Thank you. Hello?
I'm sorry, can you repeat that?
So there are two parts to my question. The first part is for tobacco screening. If in the medical record it is documented that patient is a smoker, but it doesn't say anything specifically about tobacco smoking, does that pass the screening portion of that measure?
That would suffice for the screening portion of that measure as long as it's documented in the medical record. Thanks for the question.
Okay, and then if it is documented that patient is not a smoker and doesn't ask about smokeless tobacco, would that also pass the screening part of the measure?
It absolutely would.
All right, thank you.
Yeah, thank you.
All right, your next question asks, does depressive disorder count as depression for MH1?
Hi, this is Angie from PIMS. The denominator codes in the MH coding document will include all diagnosis codes that would be included in the measure. So refer to that. The specifications state that the diagnosis code on the encounter problem list can be used to verify the diagnosis. The words major depression, major depressive disorder, dysthymia, dysthymic disorder, pervasive depressive disorder on progress notes or problem lists can be used to confirm the diagnosis. But depressive disorder alone is not one of the diagnoses included. Thank you.
Great, thank you. Next question concerns Prep 10. If a physician only screens for smoking and not all forms of tobacco, will this satisfy the measure?
Hi, thanks for the question, and it will satisfy the measure. Thank you.
Thank you. We'll go back to the phone line for Beth Tianis. Beth, we've unmuted your line, so you may go ahead.
Great, thank you. For CARE 2, screening for falls risk, would a comment such as normal gait in the visit encounters review of systems or physical exam documentation suffice for an assessment for issues with gait or balance?
This is Deb from the PIMS team, and again, we can't necessarily speak to exactly whether or not your documentation would pass an audit. However, the definition provided in the specification for screening for future fall risk does include assessment of whether an individual has experienced a fall or problems with gait or balance. So if you feel that the documentation you have meets the definition of screening for future fall risk, it would be acceptable to use. But that's something you would want to confirm, because ultimately, in the event of an audit, you would need to support what it is you report. Thank you.
Great, thank you. All right, wonderful. Next question asks, will the Prep 10 tobacco use and cessation measure be a pay-for reporting measure for the 2019 submission period?
Hi, and thanks for the patience on this. I've been looking this up. I wanted to make sure that I referenced it specifically within the rule itself. So if you go into the 2020 QPP final rule, there is a blurb or a section that covers the specific topic, and I'm just going to read verbatim from the rule. So this particular measure within the web interface measure specification collection type is redesignated as pay for reporting in the shared savings program for performance years starting in 2019, and is provided and it references a certain section of the rule, and we will exclude the measure from MIPS scoring for the 2019 MIPS performance period in accordance with some legislation. So it is in the 2020 final QPP rule. Please go out and take a look at that, and I hope that satisfies your question. Thanks so much.
Wonderful, thank you. Next question asks, for HTM2, if the record just says hypertension, can they still use that to confirm?
Hi, this is Katie from the PIMS team. So in this scenario, we would encourage you to take a look at the HTN coding document in the supplemental documentation and review to confirm the appropriate diagnosis. Thank you.
All right, thank you. Next question asks, for DM2, is the coding document considered all-inclusive?
Yes, on page 16 of the posted specification, there is an annotation at the end of the table that does say for EHR mapping, the coding within the DM2 is considered to be all-inclusive. Thank you.
Great, thank you. All right, we will go back to the phone line. Lisa Burry, we will go ahead and unmute your line so you can ask your question. All right, so Lisa Burry, you may go ahead. Hi, Lisa Burry, you may go ahead and ask your question. Okay, we will go back to Jazz Grewal. Jazz, you are unmuted and you may go ahead.
I actually have two questions. One is about the MH1 measure. For the exclusion part, if the patient has, it says an active diagnosis of bipolar personality disorder, is that meaning active as far as currently like in 2019, or is it active diagnosis of bipolar during the same time period that it's asking for major depression and dysthymia?
Hi, this is Angie from PIMS. Yes, it needs to be an active diagnosis during the measurement period.
So during 11/1/2017 to 10/31/2018.
Can I ask you to submit a case to the QPP Service Center on that one so I can double check?
Okay. And my second question was for diabetes. I know like the specs say it has to be a diagnosis of DM1 or DM2, but we came across a patient who has diabetes due to cystic fibrosis. Does that count?
You would want to go ahead and look at the coding document that's posted and see if there's anything within that coding that would confirm that as a diagnosis. And if not, I would say probably not, but if you have any questions after looking at the posted coding document, I would open up a ServiceNow ticket and we can do some additional research for you as far as whether or not it would meet, but the first place to start truly is within that coding document.
Okay, thank you.
Thank you.
Great. All right. Just a reminder to everybody on the line, if you would like to ask a question over the phone line, please click that hand icon to the left of your go-to menu on the right-hand side of your screen. It'll come up with a green hand icon next to your name, and we'll go ahead and unmute your line. All right, so next question from the chat box asks, for PREV5, if a patient has a unilateral mastectomy and therefore a unilateral mammogram, would that count, or is a bilateral mammogram required?
Hi, this is Angie from PIMS. Yes, that would count if there had been a unilateral mastectomy and a unilateral mammogram on the remaining breast. Thank you.
Great, thank you. All right, next question asks, concerns PREV6. It asks, if a patient had an office visit in 2015 and it was noted that a colonoscopy was done within the last year then and was normal, would this satisfy the measure?
I'm sorry, can you repeat that, please?
Of course. They asked if a patient has an office visit in 2015 and it was noted during that visit that the colonoscopy was done within the last year and was normal, would that satisfy the PREV6 measure?
The colonoscopy needs to be done during the measurement period or the 9 years prior to the measurement period. So if there is documentation of that colonoscopy and the year that it was done, and it is within that 9 years, then it would count. Thank you.
Great. Thank you for clarifying. All right, next question is from the phone line. It's from Michael Levant. So Michael, we have unmuted your line and you may go ahead.
Hi, can you hear me?
Yep, you may go ahead.
Okay. My question is around the, the breast cancer measurement or BESC. Can you confirm whether documentation is required that the mammography is bilateral? In the web interface documentation, for the documentation requirements, it doesn't specifically say that the documentation has to say bilateral, but wanted to confirm since we actually did lose a point on the audit last year for not having something that said bilateral.
This is Deb from the PIMS team. I would say we can't necessarily speak to, and I know you're not necessarily asking, you're just using as a reference point something that occurred during an audit last year. My recommendation would be to go ahead and open up a ServiceNow help desk ticket so that we can go ahead and look into that. I know that there is some verbiage within the specification as to what would meet that measure and what doesn't. But I think to give you the clearest answer we can, it may be best if you submit a ServiceNow case.
All right, will do. Thank you.
Great, thank you. Next question concerns PREV 10. It asks if documentation just states smoker, does this pass the screening portion of the measure, or does this not differentiate between tobacco smoker and marijuana smoker?
For that particular instance would still meet the performance of PREV 10. Thank you.
Perfect, thank you. Continuing on about PREV 10, can you clarify if it is paid for reporting for 2019?
Yep, it's within the 2020 final QCP rule, and this particular measure, PREV 10, is paid for reporting in 2019.
Perfect, thank you very much. All right, next question is from the phone line. Yana Desmond, we will go ahead and unmute your line. So Yana, you may go ahead and ask your question. Hi, Yana Desmond, you may go ahead and ask your question. All right, we'll go back to the chat box. It asks if a patient had a PHQ-9 administered outside of the assessment period, and that improvement is in the follow-up score, would this still render the measure unmet?
Hi, this is Katie from the PIMS team. So, right, in order to meet the measure, the follow-up must be conducted within that 12-month plus or minus 60-day time frame. So if any follow-up occurred outside of that window, it does not meet the intent of the measure. Thank you.
Great, thank you. All right, your next question asks, if a patient declines a flu vaccine, which would be a measure exception, is it only a valid exception if the medical record shows that the patient declines the vaccine during the flu season or at any time of the year? Same question is if it was an exception due to an allergy.
Hi, can we come back to this question as we research it real fast just to ensure a proper answer?
Of course. All right, we'll move on to, for MH1, if the patient was not on service with provider until after the denominator identification period, would the answer just be a not confirmed diagnosis? For example, if the identification period is November 17 to October 18, but the patient did not start being seen in the practice until after.
I'm sorry, this is Angie. Can you, could you repeat that just so I can be sure? Thank you.
Of course. It asks for MH1 if the patient was not on service with provider until after the denominator identification period, would the answer just be not confirmed diagnosis? For example, the identification period is November 1st, 2017 to October 31st, 2018, but the patient did not start being seen in the practice until after that date.
Hi, this is Katie from the PIMS team. So in the event that you don't have medical record documentation that a PHQ-9 was administered during the denominator identification period, you would not be required to confirm that patient. So if you don't have any documentation that they received a PHQ-9, you'd simply not confirm that patient for the denominator. Thank you.
Great, thank you. All right, next question asks, is the diagnosis of psychosis an exclusion for PREV-12 screening for clinical depression?
Hi, this is Katie from the PIMS team. So for PREV-12, there are no specific diagnosis for a denominator exception. There's patient reason for a patient refuses to participate. There's medical reason for instances where urgent or emergent situation is of essence and delaying treatment would jeopardize the patient's health, or situations where the patient's functional capacity or motivation to improve may impact the accuracy of the results. That being said, if you do have medical record documentation that the patient was not screened due to their functional capacity, that would be an appropriate time to use the denominator exception. But just to be clear, there would need to have the documentation as to why the screening was not performed for that patient. Thank you.
This is Lisa Marie. Just as a reminder, we're just requesting that if folks can submit their questions in regard to PREV-12, the depression screening measure, and follow-up plan measure, those can wait till next week, because we want to be able to address all PREV-12 questions next week. And I know if there was one question earlier in the day that regarded how to use the system with regard to PREV-12, so that was a little bit different. But any other questions with regard to PREV-12, we are asking for you just to hold off till next week, and we'll address your questions next week for sure. Again, we appreciate your patience in this time frame. Thank you.
Great, thank you. All right, just as a reminder to everybody on the line, we have about 10 minutes left of the webinar, and we will try to get to as many questions as we can in that time frame. The next question is from Jordan Ellis over the phone. So Jordan, we are unmuting your line, and you may go ahead.
Thank you for taking my call. I'd like to reconfirm a PREV-10 answer given verbally. Where in the measure spec does it reference that smokeless tobacco unknown would meet the numerator requirements for the measure?
Hi, this is Jamie with the PIMS team. Thanks for the question. I do not believe that the specification directly speaks to that. I can take a look at the specification real fast, or if you'd like, you can submit a help desk question to get down to that specificity. Does that help with your question?
I can submit a ticket.
Okay.
Yeah, we are currently not counting that as a numerator answer for this measure. So I'll submit a ticket specifically for this question.
Okay. We really appreciate it. Thanks so much.
Great, thank you. Next question is also from the phone line. It is from Margaret Alcala. Margaret, you are unmuted. You may go ahead and ask your question.
Hi, can you hear me?
Yes, you may go ahead.
Okay, I just wanted to clarify, if a patient reported a fall within the year 2019, would that suffice to meet the measure for CARE 2?
And this is Deb. I'm going to go ahead and read what I read earlier. If you give me just a second to pull it up. Basically, the definition of falls includes any documentation of a fall. So again, there has to be documentation in the medical record of a falls risk screening that includes the patient's history of falls, a described fall, a note stating no falls, or an assessment of gait or balance. And additionally, just kind of for added screening, the screening definition is an assessment of whether an individual has experienced a fall or problems with gait or balance. So as long as that documentation that the fall occurred in 2019, which is the measurement year being measured, that to me seems to fit the screening for a future fall risk, that there is documentation that the individual has fallen during the program year. Does that answer your question?
Yeah, thank you.
You're welcome. Thank you.
Hi, this is Jamie. I'm going to jump in really fast. I'm so sorry. But for the caller that had his question prior to the question that was just answered, I was able to find real quickly in the guidance of the measure, it does address smokes or uses smokeless tobacco. It's the very first paragraph there in that guidance. If a patient uses any type of tobacco, parentheses, i.e. smokes or uses smokeless tobacco, parentheses, the expectation is that they should receive tobacco cessation intervention, either counseling and or pharmacotherapy. Please submit a help desk question. We're happy to help you to ensure that you get what you need. Thanks so much.
Great, thank you. All right, next question asks, if the outpatient visit is for a fall, but the provider does not state that an assessment was used, is this still considered no?
This is Deb. I think that was answered just in the last Care 2 question, and basically you will want to look for a definition or at the definition of a fall screening, and as long as your documentation is during the measurement year, the definition of the screening for future fall risk is an assessment of whether an individual has experienced a fall or problems with gait or balance. So documentation of a fall during the measurement year meets the screening for future fall risk and can be used. The encounter type, so the visit type that came from, does not matter as long as it is documented in the medical record. And again, like all of the other documentation questions we've been receiving, you just want to ensure that in the event of an audit, whatever it is that you are reporting and submitting, you can support by your medical record documentation. Thank you.
Great, thank you. All right, we have one more question from the phone line by Kelly Collette. So Kelly, we're unmuting your line and you may go ahead. Kelly, you may go ahead. Okay, we'll move back to the chat box. Your next question asks, for HTN2, if a patient has a diagnosis of essential HTN found in 2017, is that time period acceptable to meet the measure if, of course, there is a BP done during the MY?
Hi, this is Katie. So in order to be denominator eligible for HTN2, the measure does require a documented diagnosis of essential hypertension within the first 6 months of the measurement period or any time prior to the measurement period. So as long as your documentation supports that they had essential hypertension within the first 6 months or any time prior, you would be able to use that to confirm the diagnosis for hypertension too. Thank you.
Great, thank you. All right, we've got just a few minutes left. I just wanted to check if we had an answer for if a patient declines a flu vaccine, if that would be a measure exception, and if not, if we should recommend that to the help desk.
Yep. Jamie, for that particular question, the answer is yes. But if they need more guidance, please submit a QualityNet help, or I'm sorry, a ServiceNow inquiry. Thank you.
Perfect, thank you.
And this is Deb. I don't know if you, there's another question in there that wanted clarification of something I answered earlier, and I do think I used the wrong terminology. Do you mind if I go ahead and clarify at this time?
Yes, Deb, that would be okay. Thank you.
Okay, thank you. So I was discussing the denominator exclusions and denominator exceptions. The question that had been asked for Prev 13 was about ESRD and a denominator exception. I believe I used the term exclusion, which is what caused the confusion. If you have a documented exception, you don't have to select that exception. You can, let's say you have the patient is on a statin, the patient meets the denominator criteria, the patient is taking the statin, meets the numerator criteria, but also happens to be documented with ESRD for whatever reason. You don't have to take the exception. On the other hand, if the patient is pregnant and also meets the denominator criteria, that is a denominator exclusion, and you must select the denominator exclusion because that patient was never intended to be included in the patient population. So the difference there is between the exclusion and the exception. And my apologies, I inadvertently used the term exclusion instead of exception when discussing ESRD. Thank you.
Great, thank you for clarifying. All right, we've got about 2 minutes to go, so I've got one final question. It asks for Prev 10, if a provider states that they informed the patient to stop smoking, would this meet cessation?
Yeah, that's a great question. So I'm going to read the definition. It includes brief counseling, 3 minutes or less, and/or pharmacotherapy. And if you believe by that statement that that meets the intent of the definition, I would, I guess, respond in that way. But I do encourage you maybe to submit a help desk ticket so we can, vet that response more thoroughly through the team. But thanks for the question.
Great. And just one final question came through. If a breast exam is done outside of the clinic, does it still count towards a Prev 5 measure?
This is Deb from the PIMS team. Yes, as long as you have documentation that meets the requirements of the measure, it doesn't matter if it came from another clinic. Again, as long as you have that documentation that the mammogram was performed and you're meeting all the other requirements of that posted spec.
Great, thank you for confirming. So it looks like that's all the time that we have for today. Thank you to everybody who asked a question, either through the question line or over the phone. Lisa Marie, I will pass it back to you to close out.
Great. I just want to thank all of you for joining us today. The slide deck, the recording, and the transcript from today's call will be available on the QPP webinar library in the next 2 weeks. As a reminder, our next support call is scheduled for next Wednesday, January 22nd, from 1 to 2 p.m. Eastern Standard Time, during which time we will cover the high priority bonus, end-to-end bonus, assignment and sampling FAQs, and the 2019 Prev 12 measure, and frequently asked measure questions. We hope you'll join us. Thank you, and have a good day.